that. But welcome everyone to this Community of Practice session. I think this is our 9th Community of Practice meeting. So for those of you who are new to the Community of Practice, welcome. It's great to have you here, and welcome back to those of you who have joined us before. If you want to introduce yourself and your area of work, that would be great. You're welcome to do that in the chat, and also you're free to tell us about any citizen science projects that you might be working on if that's applicable for you. But today we're joined by Kelsey Chapman, who's a PhD candidate and academic research lead, Angel Dixon, who is an OAM and citizen science research lead from the Dignity Project, and also Tamara Bosovic, who will be speaking about their experiences of using citizen science to improve experiences and systems for people with disabilities. So a really exciting session, and I know that many of us are really been looking forward to this one. So thank you so much to all of our speakers for coming along today and to share their experiences with us. Before we start, I would like to acknowledge the traditional owners of the lands on which I'm joining this session from, the Gadigal people of the Eora Nation, and also acknowledge the traditional owners of the lands on which others are joining this session from as well, and pay our respects to elders past and present, and extend that respect to any Aboriginal or Torres Strait Islander people who are joining us today. Also encourage you to share the lands on which you're joining this session from in the chat. So my name's Yvonne Laird. I'm based in the Prevention Research Collaboration at the University of Sydney, and I'm co-leading a programme of work on citizen science in prevention, which is funded by the Australian Prevention Partnership Centre. And the aim of this programme of work is to embed citizen science approaches in policy and practice settings across Australia. So as part of this programme of work, we host this community of practice on citizen science and prevention, which brings together people from research, policy and practice and community settings who really might be interested in using or learning more about a citizen science approach within chronic disease prevention. So it's a real pleasure to welcome you as part of the community of practice. We really see these sessions as an opportunity to learn from others about how they've applied a citizen science approach within their work. And it's really meant as a window into the experiences that our speakers have had with applying citizen science approaches, which you might not always see in a scientific paper. So we're really looking forward to today. If you are interested in finding out more about the community of practice, we'll share some details on that and how you can become a member at the end of the session. And just before we start as well, we also wanted to acknowledge that it is Disability Inclusion Week here at the University of Sydney, and the theme of this year is celebrating excellence, which I think is very fitting with our presentations today. So I'll introduce our speakers and then pass over for a really interesting session. So from the Dignity Project, which is a research and advocacy initiative at the Reimagining Disability Centre at Griffith University, and they were also a 2022 finalist for the Eureka Prize for Innovation in Citizen Science. We have Kelsey Chapman and Angel Dixon. Kelsey is a PhD candidate and academic research lead of the Dignity Project, and specialises in citizen engagement through innovative methods like extreme citizen science and co-design to drive change in partnership with citizens with disability. And Angel is 2019 Queensland Young Australian of the Year and is the Citizen Research Lead of the Dignity Project, and is also a passionate activist for universal design and inclusion. And we're also joined by Dr. Tamara Bosovic from the University of West of England in the UK, who used a citizen science approach as part of her PhD to examine walkability with blind and non-blind people. So some really interesting topics and speakers for this session today, and we're really delighted to have you all here joining us. I also wanted to make you aware that the session's been recorded And we also have Kylie Dunn here with us today, who'll be doing a graphic recording of the session, and we'll circulate this to everyone who's attended following the session alongside a written summary of this as well. And because we only have an hour for the session, we might not have time for Q&A, but if you have any questions, do pop these in the chat and we'll aim to get to a few of them if we have time. And our speakers have also kindly said that they're happy to answer or follow up on questions that we don't have time to by email. So I'll stop speaking there and hand over to Kelsey and Angel.
Thank you. I'll just share our screen. Can everyone see that all right?
Yeah, thank you.
Okay, awesome. So thanks very much for the introduction. We are obviously from the Dignity Project and really happy to be here today. We're going to just briefly present on creating systems that increase dignified experience for people with disabilities. So it's both the method and the results of some pilot study work that we did. Let's see, there we go.
Hi everyone, I'm the first person to go, so thanks for having me. I'll get going on our first slide, which has a graphic of an overlap of flow, which is building things, treat people, and the way we work. So the project itself is a research and advocacy initiative at Griffith University and is a flagship program at the Hopkins Centre. It was developed in response to research that revealed that people with disability and impairment experience violations of dignity and suffer inadvertent harm through systems of care. So the Dignity Project is led by people with and without disability, myself and Kelsey, and a few other people on our team, citizens and academic researchers in partnership to deliver meaningful outcomes and social change which promote dignity. Over the past 2 years, the project has undertaken a suite of projects to understand what dignity means for people with disability and how to ensure that people with disability have dignified experiences and interactions in mainstream services and systems. There's a lot of information in our presentation. We have a lot to talk about, so we've tried to condense it into 20 minutes. The aim is for us to quickly highlight 4 key recommendations that have been aggregated from across all of the studies that we've conducted over the last 2 years and give you a bit of insight into our approach on how we do this. So on our next slide, there is a quote from one of our citizen scientists that says, "Undignified treatment makes you feel not worthy. To be honest, you feel like less than a human." Dignity is a complex and multifaceted concept with a range of bioethical, physiological, and practical considerations. Philosophical, sorry. The provision of dignity for people with disability is enshrined in numerous frameworks and pieces of legislation. Dignity is typically conceptualized as either inherent, something that people are entitled to on a basis of rationality, agential action, and autonomy, or as contingent, so it's influenced and potentially violated by people, or personal, cultural, societal, and relationship factors. Both conceptualizations of dignity present challenges for people with disability. People with disability are often denied full status as human beings by legal and societal norms and may experience limits to functional capacity as related to autonomy, rationality, and independence. Dignity is an upstream determinant of participants' experiences of care and health systems, as it can directly influence patient and customer satisfaction, feelings of personalisation of care, and the delivery of optimal preventative services. Undignified interactions with systems and services can increase people with disabilities' feelings of dissatisfaction and humiliation, can lead to withdrawal and social isolation, and can increase risk of chronically poor health and mental health. Despite critical importance of dignity and as articulated in legislation and frameworks, and as supported by people with lived experience of disability, it is necessary to move away from current conceptualizations of dignity steeped in the normative dynamics of ableism.
So just a quick overview of our extreme citizen science approach. Obviously, it's a atypical citizen science application, but citizen science, when conducted with and by people with disability, is a form of enablement in research. In the Dignity Project, citizens with disability are regarded as experts of their own life experience and of their impairments. So we adopted a framework that we developed over a series of working group sessions for, like I said, extreme citizen science, a term which is coined to define an approach to citizen science that maximizes inclusion and participation and has emancipatory goals for change. This goes beyond the notion of amateurs assisting qualified researchers in data collection and analysis, and embeds citizens as integral drivers of all phases of research and also as integral partners in our research. We grounded everything in the UN Convention on the Rights of Persons with Disability. That's, our theoretical approach and our theoretical framework around language. And conducted the project, various projects we're going to present the results of today with consumer leaders embedded throughout the research process, which was iterative across these 5 phases: vision, uncover, discuss, critical reflection, and change, and utilized a digital platform which we developed in partnership with citizen scientists, which currently has 200 plus members who are all people with disability and have diverse impairment.
Which brings us to our first key recommendation, which is universal design and eliminating barriers. Unless you're creating something new, there'll always be a mutable infrastructure that presents challenges to each of the outline recommendations that we have brought to life. What we've strived to do with the recommendations is to activate new ways of thinking to increase flexibility in what seem like rigid places, particularly within health systems. In many ways, these recommendations react and rely on each other. The first, obviously, being universal design. Ensuring equitable access to comparable opportunities and experiences is critical to dignity for people with disability. Barriers negatively impacted on participants by creating a sense of dependency, increasing anxiety and emotional distress, and increasing social isolation. Dignified interactions were shaped by interactions between people, infrastructure, and physical, cultural, digital, and social spaces they traversed. Universal design is a method of designing based on 7 key principles that work to make environments, services, and products usable by the highest number of people. Some of the universal design principles include flexible use, simple use, and tolerances for error. Oriented around all of these principles is the goal of removing barriers for all users. Co-design is another element that is part of each of our recommendations, and it's an important part of universal design. The act of actively involving stakeholders in design processes from the ground up, not just at final user testing, almost certainly guarantees optimum user experiences, effortless interactions, and ultimately business benefits. So it builds acknowledgement into the fibres of creation, and acknowledgement was a significant theme present throughout our research. It's a defining factor for people with disability when we talk about dignity. And when each of these recommendations are met or addressed, people with disability are acknowledged, not just on a basic human level, but as contributing worthy citizens who can enjoy their human rights, which goes back to our CRPD foundations. So the key recommendations that we have under this heading are decisions about funding and spending must include marginalised voices, co-design and collaboratively identifying priorities for improving access. New construction should always adhere to UD principles and retrofit existing infrastructure, and if not possible, seek alternative means for inclusion.
Our next key recommendation, sorry, just to back up in the explanation of, what we did, all of our research was qualitative in nature. Forgot to mention that. So we did a range of activities with citizen scientists to develop these recommendations. Our second key factor for dignified experiences in interactions with systems and services is information, and that improves system navigation, but also sense making about the way people with disability want to interact with a system or service if they choose to interact with that system and service. So our participants and citizen scientists engaged in sense making activities by acquiring knowledge about personally relevant details like location of amenities, parking availability, the inclusive nature of the care provider, where to go, and whether they might feel safe and comfortable interacting with that system. Most of this information was gathered during what we called wayfinding, so that's during that sense-making period. Research citizen scientists describe the importance of inclusive, accessible, visible, transparent, consistent, and accurate information as a mechanism for maintaining dignity. And dignity was positively impacted when that information was easily and independently accessible and when it could be used reliably to support sense making. Inaccurate, incomplete, inaccessible information compromised dignity, increased frustrations for our citizen scientists, and decreased confidence in interacting with the system. Designing inclusive and accessible information for sense making requires attention to a very broad range of factors. Information can be gathered from websites, mobile applications, social media, from staff, fixed infrastructure, and by observing and interpreting what's happening in a space. Information might be dynamic. Other information doesn't change very often. And dynamically changing information was particularly challenging for dignity and requires further inclusive means for communication. Our key recommendations under this theme were that information needs to be visible, audible, and easy to understand, should be transparent and easy to find, should be consistent and accurate, and of course, should be as real time as possible and in language that's either plain language, easy English, or pictorial language as needed and as required to make it as inclusive and accessible as possible. The next key finding was the importance of frontline staff. And I think that is probably pretty obvious, right? Staff in a system is critically important to how people with disability experience dignity in that system. But diverse perspectives and individual factors can make that really challenging. Almost all of our research, citizen scientists and participants across 3 studies mentioned staff, particularly health service staff and other frontline staff, as being critically important to retaining a sense of dignity. Many interactions that we discussed illuminated positive experiences where staff were supportive and helped with negotiating access challenges. Staff who recognized participants' individual impairments and acted in ways that preserved dignity, had calm and respectful attitudes, talked directly to people with disability as opposed to their support person, showed empathy and understanding. However, instances where staff asked intrusive or unnecessary questions, like around disclosure of personal information, had attitudes that lacked acceptance and understanding, or required participants to prove they were disabled, left participants feeling undignified and very vulnerable. Our key recommendations are to develop systems that support staff to be engaged and empathic, which means that organizations need to address their organizational internal pressures. That might be time, resources, skills. It might be COVID-19, which was a big emerging factor, of course, during our research. And that increases the opportunity for staff and their motivation to act empathically. We recommended that organizations identify and measure the factors that contribute to empathy and respect within their own organization and implement system-wide empathy training that's co-designed by people with disability. Attitudes towards an awareness of the needs of people with disability is of critical importance when working to ensure dignity. Failure to accommodate the needs of people leads to undignified interactions, and competing time, resource pressures, pandemic, prioritization of services, and organizational policy all work together to contribute either positively or negatively.
So we're up to our next one, which is creating space for voice, choice, and independence. Recognizing the diversity of impairment and disability increases comfort, security, and feelings of respect for people with disability when interacting with systems and services. Participants across all 3 studies discuss the heterogeneity of lived experience and the desire for systems to provide flexible services and care provision based on individual preferences rather than medical diagnosis or, going back to the attitudes, assumed functional requirements. Participants closely related dignified interactions with systems and services with the opportunity to express agency through voice or preferences, and independent, although independent may sometimes mean supported, decision-making. Our key recommendations under this heading are creating opportunities for people with disability to express their preferences, embed opportunities for choice and agency in policy and procedure to support staff engagement, regularly review preferences and choices to respond to fluctuation in impairment and capacity, and co-design system change policy and procedures with people with disability. Embedding opportunities for people with disability to express choice and enact independence should be implemented across policy and procedure. Activities similar to palliative care patient dignity question, which asks, what do I need to know about you as a person to give you the best possible care, should be examined, implemented, and regularly reviewed to reflect continuity of care, but also the fluctuation and changing of preferences and capabilities. Policy and procedure change to embed space for expression of voice, choice, and independence will be bespoke and consider the organisational constraints and factors of each service. But community consultation and understanding co-design of system change is imperative in order to better understand the system-specific barriers to limit voice and choice. On our last slide, we have another quote. Which is, dignity is making sure my wants and needs are respected and I'm not treated like some inspiration or burden, which is something that we find often. The attitudes towards disability are very polarized and there seems to be not much middle ground. The last 2 years have revealed the depth and breadth of the work that's actually required to ensure dignity is preserved for all of us when we're interacting with health services and environments. It will be a long road for Kelsey and I, we feel, and for anyone else who is diving deep into this area. We hope that this little bit of our research has scratched the surface and that some of this has made sense to you today and perhaps inspired you to do something with citizen science or reach out to us and we can do something together. And thank you for having us.
Oh, thank you so much, Kelsey and Angel. What a fantastic project. I have lots of questions, but in the interest of time, we'll move on to Tamara first, and then hopefully we'll have a little bit of time before we wrap up to answer any questions. But thank you so much to you both. That was fabulous to hear from you. So I'll pass over to Tamara.
Excellent. Thank you so much. Yeah, I also had the questions, but yeah, and I'll try to stay to keep it short-ish. Excellent. Hello, everyone. I'm Tamara Bozovic. I used to do my PhD in New Zealand and work in New Zealand. And I'm now in Bristol, and I would like to talk about the use of citizen science in my PhD. So I will just quickly give a bit of a framing where this project set, and I think the two main things I would like to provide you as a takeaway is, on one hand, the findings of citizen science as opposed to interviews and ways how those can be the nuances we can have between the two, and the other is really the in terms of methods and how to apply citizen science, for instance, with blind people. Yeah, sorry, I found how to. This is the image shows a big intersection, which is actually just at the limit of Auckland city centre. So Tamaki Makaurau, Auckland, that I'm going to call Auckland for simplicity in the future. So my interest was, how do we go from a situation that is now was called a peak hour traffic machine by Jan Gehl? How do we go from there to a place where walking is part of the preferred modes of transport for people, and a place that has a carbon neutral system? Just a word on me as a background. I come from a transport engineering, so really from very quantitative, math heavy education and background, but I've always been interested in how transport contributes to livable cities, and I'm really interested in this decision making, in how do we retrofit, for instance, infrastructure that we inherited. In terms of walkability, we speak a lot about destinations and the need of having higher density and more destinations, and that is absolutely crucial, and that's a long-term ongoing effort. Now, what interested me in my PhD was what happens today and tomorrow. So here on the right, the photo shows a very wide road, and on the right you have some, on one side of the road you have some shops and fast food. So what happens when destinations do exist, like here on the right? So what interests me is the experiences of those who do walk right now, like this man who is crossing the road carrying a little girl. And I'm also interested in who is not there, and why are those people not there? Did they maybe stay at home, or maybe are they in this black car doing a short journey? It's the kind of things that we don't really know very well in transport planning. We count vehicles, but we don't really know who is maybe driving trips that don't need to be driven. So I'd like just to situate my project within the theoretical model that we have called the social model of walkability, as an intentional nod to the social model of disability. So the model very briefly relates the walking environment and the transport system to walking as a behavior, choosing to walk, choosing not to walk. And in the middle, you have this hierarchy of walking needs, and it's really people's perceptions, how people perceive how their needs for walkability are met. And it goes from the most basic, being feasibility, to more sophisticated needs such as pleasure or ethics. And all those elements are moderated by individual, social, and trip-related factors. So in my PhD, I was really interested in disability as a moderating factor, and I would like to make a very quick note on language. I will always refer to disabled people based on recommendations of disability scholars and disabled people themselves, and in aligning with the social model of disability. So I'm talking about people who are disabled by their environment, and I'm not talking of inherent characteristics of a person, which would be their impairments. I would also like to outline that I do not identify as a disabled person, which is a problem, I think, in researching disability, and also a reason for using citizen science and working more closely with disabled people. So the citizen science project happened after a series of interviews. So I've interviewed 56 people, half of whom were disabled, and with each person I talked about the destinations they usually walk to, and for each destination we talked about the route they choose and the barriers they encounter and discussed what those barriers are, and then I was able to go on the ground and identify and measure those barriers. And we also importantly talked about places that they would like to walk to, but they cannot, and we were again we discussed why those places are inaccessible to them, what the barriers are. And so every time a person would talk about a barrier, for instance, a non-signalized crossing, I was able to go on the ground and really gather metrics around that crossing. So all my interview participants were invited to continue engaging with the project as citizen scientists. 9 initially accepted, and 4 completed all the steps. I would just like to mention that I don't have the time to really talk about all the information I gathered from the interviews, but it was extremely rich, and a 6-minute video was made showing some of the places people talked about and with quotes of the participants. So I really encourage you, and we can share this link I think it was a great illustration done by a filmmaker. Now, citizen science. In this project, citizen scientists were involved in quite a few steps of the project. And in the interest of time, I would like to just focus on data gathering, because that's, I think, where we had interesting elements regarding the accessibility of data gathering tools. So we were using the discovery tool Our Voice, which is a mobile phone app made by Stanford Medical School. So the screen shows screens on the app. When you open the app is really designed to be quite simple and easy to use. So when you open the app, you can start a walk. And from the moment you start a walk, the app is going to record where you walk. And then at any point of the walk, you can take a photo. And then for the photo, you can, the app prompts you to say why you took this photo. So it can either be a text input or a voice input. And then the app asks, is it good or bad for the community or both? And it's as simple, and then you save and you continue your walk, and you can take another photo and then you finish your walk. So the data gathering is quite simple, in theory. I would like to just give a bit of an overview of the 4 citizen scientists who worked with me. So 4 people aged 40 and above. 2 of my citizen scientists are blind and long cane users. One has some difficulty seeing, and she's also the primary care of her husband, who is older with difficulties walking and suspected dementia, which adds to the complexity of walk. And one citizen scientist identified as non-disabled and is a keen walker walking long distances. So we had quite a range of diverse people, and I would like to say that my 2 blind citizen scientists, one works full-time. They are both very active. One works full-time and the other is retired and volunteers I think every other day of the week. So the organization of the project was, we had 3 workshops, which were really the way to provide some training and some information about the project and allow citizen scientists to know each other. And then we were checking in, and those other workshops also were related to other tasks that I'm not going to get into the detail about here. So about data gathering, so I mentioned the app, and the citizen scientists were invited to walk wherever they like. It can be in their neighborhood, it can be somewhere else. And so they can choose which walk they want to record, and they could choose for each walk what they want to talk about. And they knew that the project was related to the walking environment. And so they were prompted to talk about anything that they think contributes either positively or negatively to the walkability, and provide their insights around why something might be a barrier or why something might be an enhancement or a support for walking. In terms of methods, the app revealed relatively hard to use for blind people. First, blind people need text to voice that is going to read to them everything that is on the screen, and even if the screen is quite simple, this takes some time. And the other problem was that the app is really related to taking photos. So my blind citizen scientists were not really at ease with taking photos because they knew that they were going to take photos that maybe photos of the sky. So we discussed adaptation. The first was to use the app and just ignore the photo. Even if it's the photo of the sky, doesn't matter. What interests me is their description of what they are seeing, or of what they are encountering, and why this is a barrier or something that is positive. The other option was to walk with a simple dictaphone, which one of my citizen scientists did, and the dictaphone is easier to use because it has tactile buttons. And of course, so we skipped the element of the photo, but had the person's thoughts and feedback. I also offered them to walk with another person, either another citizen scientist or a person of their entourage, or to walk with, here I said the primary researcher, which was me. So one of my blind citizen scientists walked with his wife, and his wife was taking the photos, and the other did some of his walks with me, and he would instruct me to take photos and tell me what to take photos of, and then he would record a voice message about why this photo matters, and then he also did some walks with a dictaphone. So here is just a quick map of where the citizen scientists walked. So we had 12 walks using the app and 97 inputs, i.e. 97 aspects of the built environment. And the big dots are the places around the people's home, and the smaller dots are other places. So you can see that Ethel and her husband, they like to take the bus and walk in different places. So they explore different parts of Auckland. The reported features, so majority, 74%, were tagged bad for the community, while the minority was considered good. And almost all the features were related to the qualities of the walking environment. So there was a lot of inputs about footpaths, crossings, and most of those were really associated to the basic needs, feasibility and safety of walking, namely. And there were 2 inputs about public transport services and information as supports to walking. The features that citizen scientists reported had already been noted in the interviews, except 2 new features: shared paths and information. I just would like to give a couple of snapshots. So those are photos submitted by the citizen scientists. So here is Lenny saying, in our family, this is known as the killer tree. And you can see that the tree is very low. And Lenny walks with the long cane. And of course, the long cane does not allow him to detect this major barrier. And this is Ollie saying how he can't see the cars. So Ollie is also blind, walking with a long cane, saying how he can't detect a car that is going downhill, and he doesn't know if the car is going to turn or not. So he really has to wait until there is no one to be able to cross. Even in this little street that he's crossing, there is not much traffic, but any car he hears going down the hill could potentially turn right. And here Lenny saying that this is a crossing and it has tactile pavers, but there is a lot of traffic and the traffic is not going to stop. So he says they're tactiles, but the crossing is useless. I would now like to know, I'm not maybe going to spend time on this, so it's really the feasibility and accessibility issues were about crossing, absence of crossing, design of crossings, footpath obstructions and crowding and being forced to zigzag or to share with cyclists. I would like to just spend a second on citizen science versus interviews, because in this case we had the same people talking about similar environments, their home environments and Auckland in general, and either through interviews or through citizen science. And I think it was really interesting to see that through citizen science, there was really more richness in the detail of the observations and the micro features. Maybe on a stretch of 200 meters, there could be 10 features that force a blind people to zigzag maybe on the footpath. And with an app that is easy to use or a tool that is easy to use, it's relatively easy to record each of those features, whereas in an interview, it's quite clunky because for each of the features, I'm going to ask a series of questions, and I can imagine that the person doesn't want to go through 30 features. Possible differences is the method, the form of data capture, but also the scope, because in the interview we talked about the usual walks the usual walks, whereas the citizen scientists could walk anywhere and so potentially encounter new environments. Last thing I would like to mention is just the potential for more inclusive methods. So the idea of Discovery Tool is to be accessible to almost everyone, and we have, as we can see, that it is not really the case for blind people. So an idea for future improvements would be to have a wearable camera and recorder, including GPS tracker, and physical switches to take a photo, capture voice recording, save, pass to next, start walk, stop walk. So it could be something relatively simple, but it would need to be designed so to be useful, to be usable independently by blind citizen scientists. And I have forgotten to note that this is, to my knowledge, the first citizen science, app-based citizen science study working with this with blind people. This is me. Thank you very much for your attention, and yeah, happy to either take question now or by email. I'm going to stop sharing.
Wonderful. Thank you so much, Tamara. What an interesting project. And again, it's raised lots of questions for me. And we've got some time. We've got about 10 minutes. If people have questions that they would like to ask any of our speakers. So I will pause there and allow people, please feel free to add a question into the chat or to unmute yourself and ask our speakers directly. I'll pause there and see if anyone has questions they'd like to ask before I jump in with with my own. Oh, well, while people are okay, sorry, there's a question there for from Caroline there. So thanks very much for the great presentations. Any comments on sample size? I'm not sure if this is, Caroline, is this aimed at Tamara, or is this aimed at all of the speakers? I don't know if you want to clarify that. Okay, that's a question for everyone. So I'll ask Tamara to speak on that first, if that's okay.
Yes. So in my case, I had only 4 citizen scientists, and I really do think that it would have been great to have a larger number and have people with diverse impairments. So for instance, one wheelchair user was initially interested in participating, and I do think that they would have had, again, a specific perspective. Also in my interviews, I didn't have any, for instance, deaf person. So I really think that we need to better capture the diversity of people's individual impairments and experiences. And from that point of view, a larger sample size would have been really useful. And in this case, I had to work with the sample I had.
Yeah, thanks, Tamara.
Yeah, so across our 3 different studies, obviously our approach to citizen science is just slightly different. So Angel obviously is our lead citizen scientist, but is embedded into our research team. And then across the 3 different studies, we had 22, 26, and 7 as our sample size. And our samples are really purposive sampling for the same thing that Tamara said, to represent a diverse cohort, both from impairment perspective, but also socioeconomic factors, gender, amount of time that they have been living with their impairment, whether that's congenital or acquired. So just a range of factors. And I would say, you know, in terms of robust outcomes for a small sample size, you know, I guess we're qualitative people. So we go off the idea that, you know, you can have thematic saturation in as few as 6 to 8 citizen scientists. But of course, you know, the more diversity you can capture, the better. And we just work off the principle of like qualitative generalizability rather than statistical generalizability. And so far that seems to be fairly rigorous and robust for us.
Wonderful, thank you. Carolyn's just added, I know that many citizen science projects relating to tracking nature are much larger, so they have more reliability. So it'd be great to use citizen science and health for other purposes. Yeah, absolutely. I think you just add into that point, we certainly see those bigger scale projects within other disciplines and not so much within the health space. So there's definitely opportunities there, I think, to have citizen science on a bigger scale within health. And then I'm just reading a comment from David in the chat that we're setting up a running club with a plan to establish a triathlon club for people with disability. Yeah, David, do you want to say anything about that to the group?
Thanks, Yvonne. Yeah, recently did an Ironman with one of my clients who's visually impaired, and he now wants to set up a running club for people a little bit similar to himself. And yeah, there's not that much opportunities where I'm at for people with disability, particularly in triathlon. And yeah, just thinking about citizen science, and I'm very much only just starting to get my head into it as I've just met Yvonne recently. But it's how we could maybe look at that in terms of how we go about it, and yeah, that's so I just kind of put it out there for maybe a discussion offline.
Fabulous, thank you. And while I'm just checking on, we've still got a few moments left, so there's still some time if other people have questions that they want to ask. But while people are thinking of any questions that they might have, any burning questions, I do have a couple of questions for both of you that I'd like to ask, if that's okay. Kelsey and Angel, I'm really interested what's next for the Dignity Project. You've done such a fantastic kind of, you've done such fantastic work so far, and it's great to hear about it, but I was really intrigued about what your future plans are.
Yeah, do you want me to go with that, Angel? So we're actually working on a project at the moment, which Carolyn's comments very timely, doing a evaluation of dignified health experience for rehabilitation patients or people undergoing rehabilitation-like care at the Gold Coast Hospital. And, using our same method, our research team has 2 lead citizen scientists, and we are co-designing a new model for dignified rehabilitation care within that system. So that's kind of our immediate thing that we're working on right now. And we're actually in the process of upscaling the infrastructure for our platform. So previously we, as probably many people can relate, small budgets for citizen science projects. And we built our platform essentially for nothing and used those 2 years as a test case for the viability of the platform. And it's gone really well. So we're now just upscaling into a much more accessible, more inclusive platform that has both front-facing and private spaces for people to engage and participate, with the vision of using that as an employment pathway so that people can professionalize their lived experience to participate in other citizen science projects or other research. And so, also applying for lots of grants too. So.
Fantastic. Well, it would be really great to continue the conversation with you both about maybe how we might be able to work together in the future, connect with your team, because you're really doing fabulous work. And Tamara, we also have lots of interests in the built environment, walkability space within our project as well. And yeah, I guess there's lots of questions I have for you, but we've not got very much time left, so I'll just limit myself to asking you one. But I guess you mentioned that you involved citizen scientists in kind of multiple phases of the project. And I wondered if you got insights from the citizen scientists in terms of some of the recommendations that you were suggesting for the different approaches that you could have used instead of the discovery tool, and I guess related to that, how you would maybe do things differently if you were to, be able to get more funding to do this type of project or now.
Yeah, I think if I had more funding, I think I would really love to have developed some maybe 3D printed device that people can use, because what I have seen from my blind participants is really that they want to be independent. For instance, Lenny works full time. He commutes, he goes on foot to take his bus and then takes his bus and goes to work. And it would be easier for him to be driven by his wife, but he really wants to be independent and it's really important to him. So I think it's just part of, and I just want to mention to Kelsey and Angel's presentations, I think dignity is such an interesting lens. And for me, it was participation and inclusion and ability to participate, but I really do think that it's related to dignity of being a full citizen. So in the terms of citizen science as well, I think it's really important for anyone to be able to participate and not to depend on another person or feel bad because they are taking photos of the sky or of their feet or have to walk with me. So, and I really think that it wouldn't be a major development. I really think, well, now GPS trackers cost almost nothing. I mean, it could be like literally a dictaphone with a GPS tracker. Yeah. So that's what I would really like to do, something that is that allows people to be independent.
Yeah, fabulous. Thank you so much. I still have lots of questions for you both, but we'll stop there in the interest of time. And I just have a slide to share with you all, so you bear with me until I find it. Why did it not come up? I'm not sure why. Perhaps while I'm trying to find my window. Pippi or Leah, if you could pop in the link to the survey in the chat, the feedback survey, that would be great. Yeah, sorry, I don't know what's going on with my Teams, but I'm not able to share my slide. I don't know if Leah or Pippi, if one of you could share, but I'll just as I'm wrapping up, I just want to say a huge thank you to all of our speakers for coming along and sharing your work with us today. It's been a real pleasure hearing from you, and it's given me certainly lots of food for thought in terms of thinking about our future plans and programme of work, and what we might be able to do in the future. And I'm sorry that we didn't have more time for questions and discussion, but we'll share your contact details with the speakers. If you do want to connect, then that would be fantastic for you to do that. And as I said, they're willing to follow up with you if you do want to connect. And as I said at the start, we will also share the graphic illustration that Kylie's put together in the session, and a written summary of the session as well with you afterwards, if you want to refer back to that. And yeah, thank you again, everyone, for your contributions. If you don't mind completing a short feedback survey, that would really help us improve our future sessions and inform some of the